Okay, so this live is going to be about. So this live is going to be about clinical reasoning. So I've labeled it "How to Think Like a Physio" because it sounds better than clinical reasoning. But we're going to talk about what the process is from when someone comes into the front door to their first follow-up and beyond, how we make our decisions. It should give you a better understanding about, what it is that we are trying to achieve whenever we're trying to help someone with physiotherapy, and also, making our decision making based on the do's and don'ts, right? So what is necessary and what falls short of that, as well as what different types of pathologies there are we need to think about. So whenever we are concerning ourselves with, okay, what is it that we need to do for a particular client, it's mainly based on what the information that we have on the subjective side of things. So the subjective is the symptoms that someone's feeling, their day-to-day aggravations and eases, their history, medical history, those sorts of questions that we have. Now, when we are going beyond that, we want to then think about, okay, based on the information they give us, how are we going to clinically reason? When I say clinically reason, we're talking about our evidence as well as what we feel based on experience. We are going to formulate a plan. So there's a couple of ways that we can do this. It's been taught multiple ways and more beneficial. Different clinicians will use different things, but one of the things that uses Moscow, which is must, should, could, would, that process. But what I like to use is just must, should, could. And what we're looking at is, from a must standpoint, it's whenever someone comes in, we have half an hour, right, to do a full assessment. And within that, the subjective side of things, the question taking, the question answering will take, a good chunk of that, about 10 to 15 of that. Now, if we want to be as effective as possible, we need to think about, okay, what is it that we must do? Now, when we think about the must-dos, is about the things that are most serious, the things that we as physios cannot deal with. So, do we need to do a specific test that will rule out particular injuries that we cannot help with? Now, when we're thinking about that, if I were to take, for example, a knee, when we look at a knee, we're going to test, okay, what are the things that we can't deal with? The things that we can't deal with are full ligament tears, fractures, any other more serious pathologies like that. Now, when we think about why it's under the must list in terms of what we need to test, it's under the must because it is something that's quite sinister and serious that needs to be dealt with immediately. Now, as soon as we've ruled that out, we then move into the shoulds. Now, when thinking about shoulds, we're thinking, okay, I think based on the information that someone has provided to me on their condition, I think that this is the potential diagnosis that could be present with them, or diagnoses, so multiple diagnoses based on the information given. Now, when we think about that, we are going to say, okay, there are some specific tests, either special tests, range of motion tests, muscle strength tests, that are going to give me the best information, best answers to the information I already have, right? Now, when we're thinking about that, let's say take a knee, for example. If I think that they have an issue with their kneecap, then I'm going to do those tests based on what we've learned at university, etc., and studied, that are going to rule out, do they have that issue that I think they have, or is it something else? Because a lot of the time when we look at something, when someone describes their pain, it might not actually be present in that area they think it is. And that's called sort of referral of pain. Now, once we do the shoulds, so once we have done the must and the shoulds, what we should have now at this point is a more condensed idea about what someone has. We don't know for 100% sure until we get imaging, which is not available to everyone. But once we have formulated the must and the shoulds, we then can move on to the coulds. Now, the coulds are basically everything that we have not done that may be saved for a second appointment or third appointment in order for us to, okay, we're just going to have a look at this. I don't think it's the case, but we might as well, and it will give us a better picture about things overall. For example, this could be looking at some more functional movements like a squat, a sit to stand, a lunge, because these are some things that in someone's day-to-day is actually going to be quite relevant and quite important for them to do. So if we can then, at that point, once we've done the must, shoulds and coulds, we then can formulate an idea about the diagnosis, one, the treatment plan, right? So that includes manual therapy and exercise therapy. Once we combine those two together and formulate a good progression of exercises and sessions, then once we build that together, then we have the best chance possible at achieving what would be a good physiotherapy prognosis, right? So we can say, based on, if I have done my assessment correctly, and if I know that this, if this diagnosis is what I think it is, and we have done some ruling out of the things we don't think it is and the things we do think it is, then at that point we can have a much better chance of getting you to back to your best and even beyond that. So now that gives you an idea about the clinical reasoning and why we do things. But beyond that, we're going to think about, okay, if we are thinking about clinical reasoning for what we know about, okay, so the reasoning for what we know about, we can then move on to looking at the things that we are not 100% sure about. And this is where we can do some research, because not all physiotherapists know everything in that one instance, right? But we can look at further research in between sessions. We can formulate a plan based on if things go wrong. So, for example, we think it's one thing based on the assessment we've done, and then from that we can then say, okay, our first bout of exercise and manual therapy, let's say for the first number of weeks, usually we do a reassessment at 3 weeks. We're thinking about within that time frame, okay, have they got better based on the plan that I've made and the treatments, the assessment that I've done? If we do not see as much of an improvement as we expect to see based on research, right? Where everything we want to do is evidence-based, so everything will be based on research. If we have, not successfully formulated the best plan possible, or may need a few tweaks in there, that's where the reassessment will come in, and that's when we can make some retweaks, okay? So once we have made some retweaks, that is something that with physio is always ongoing, so we're always going to make some changes here and there, because what happens is your symptoms change. You might see, for example, I've been using knee as a main example, you might see that, okay, the initial pain that you had has now moved elsewhere and has now started to be something that's a little bit more localized elsewhere. It may have been quite a widespread area of pain, kneecap, thigh, down into the leg, and now it's more specific to a particular point in that kneecap. Then what we can say is, okay, we can move away for the more general exercises and we can move towards more localized areas, because usually what we see is when it comes to symptoms, they can be quite widespread and they tend to localize once we have started to deal with the symptoms initially, right? So the clinical reasoning, the understanding we have is we do the must, should, could list, which is a part of the assessment. We then Based on that list, we then formulate a treatment. Once we formulate a treatment, we make tweaks to that treatment. Now, if we see that our reasoning and our understanding and our thought process has worked, we can then move on to taking you into more long term. And when we're looking at long term, we want to make sure that everything that they have done previously is progressed upon, right? So we don't want to be stagnant in one place. We want to always listen to not just, so the reasoning isn't just about, okay, what's happening at a mechanical level, at a movement level. We also want to look at, is there anything that is going on in someone's life that we might need to adjust and make changes based on what we are telling our clients and educating our clients about, right? So we might have to look at the broader, more holistic framework, not just look at the issues that they're dealing with, but also some other things based on their biopsychosocial, so their life, and also based on the progression of someone's symptoms and injury or disability, etc. Right? Now, once we have done all these things, so we have looked at the assessment, treatment, and moved on to more of a longer term plan, what we're able to then say is, okay, at this point, is this someone who has had successful physio, yes or no? And then what we can do based on that is, okay, this worked for this person, we can then tailor that same program elsewhere, but also make sure that we are specific to that one person. So when we are thinking about our treatment plan, and assessments, we're always going to be specific to that one person, but also use our the evidence that we have found previously to then build a case and build a better understanding for similar type of injuries. The last things that I want to mention now is, okay, when we're thinking about, okay, how can I think like a physiotherapist, we do have to make sure that we aren't, and what can often happen is, based on, let's say in a busy NHS setting, we focus on just the thing at hand, and we have to make sure that we are looking at the bigger picture as much as possible, while also being very specific at the same time, which is quite a difficult thing to do. But looking at things from an evidence-based perspective, and also just intuitively, we combine the two together, and then it gives us a better outcome out of the entire process as a whole. Okay, good. So that's live about clinical reasoning, and hopefully it makes a lot of sense to you as about what we do and how we're thinking, and hopefully you can see the benefit in that.